think we'll end on a hot topic. We don't have to get into details, but I still get questions all the time about proton therapy. And we do not offer proton therapy at CSNF. There are multiple locations in Jacksonville which do offer proton therapy. If a patient comes to you to ask about proton therapy for treatment of their breast cancer, treatment of their lung cancer, treatment of their colon cancer, well, not colon, but let's say esophageal cancer, what do you guide patients on the most appropriate indications for proton therapy compared to standard conventional radiation?
Yeah, I think it's obviously a question I get a lot too. I think the bottom line is one's not inherently good or bad or evil or better or worse. It's really, there's a lot of factors that go into it. One, as you mentioned, is what's the disease, what's the clinical scenario. Number two is what's the technology. Are we comparing apples to apples? Even within protons, there's more modern proton therapy, which can, better modulate the dose versus more traditional passive scatter, fixed beam arrangement protons. Same thing with kind of conventional photon therapy. You have rudimentary sort of, fixed field 3D radiation all the way up to, VMAT or, radiation, which is where we can treat 360 degrees, angles and, modulate the dose that way. So some of it is where are you going? What technology do they have? What's the planned treatment? So there's that piece. The the bottom line really is the the particle that's coming out of the machine is different with protons. It's a proton ion, so it's a charged particle with mass, versus obviously a photon or what like a classic linear accelerator or traditional radiation is basically it's a electromagnetic wavelength spectrum thing that comes out of the machine head, so something without mass. And then when it hits your skin, it turns into electrons, and it's the electrons that are doing the damage, versus a proton. When it hits your body, it's partially the protons doing the damage as well as bystander effects of creating other ions. But the mechanism of action of damage between the two is essentially the same. They're both, in a traditional sense, damaging the DNA of the cancer cells in a higher rate than it's damaging the DNA of your healthy, normal skins or normal tissue cells. So that part, in terms of how it kills the cancer, is very similar. The reported, or what was hopefully supposed to be the benefit of protons, were if you imagine a radiation beam comes in and this is your target, it hits the target, and where proton beams and their dosimetry, because of their biological properties of mass and things, there's no or minimal exit, what we call exit radiation, so radiation beyond the target. So that's
Mhm.
why we thought for a long time they would be, superior to conventional photons.
Right.
Well, the issue is, early on, I think not as much anymore, thankfully, we didn't really understand what was happening biologically at the end of that proton beam. So we were seeing side effects, very serious side effects actually, for things that were happening at the junction of a tumor and a normal tissue. So if you had a tumor butting up against the brainstem in certain kids' tumors, or situations like that, we were seeing higher rates of necrosis or damage or things than with conventional radiation, because we underestimated what the biology of that proton beam was happening at the end of the beam. So to make up for that, a lot of the newer protons um, models use different numbers to estimate that. And then they obviously now also come in at multiple angles with protons, so sort of similar to photons. The cynic in me would think, if this is your target and you're coming in with a proton beam from one angle, and the goal is obviously less radiation on the back end, but you're coming in with another angle right on that opposite side where the end result is similar, because you're coming in still from both sides. There's dose in the middle and there's dose on the way the beam's in. So
Right.
in that sense, it's lost some of the, in my opinion, at least, the purported benefit of it. Now, with newer proton machinery, there is a better dosimetry. They can now start to come around at more angles, sort of similar to what we have with VMAT or arc therapy. So I think that part of it is getting better where it's more conformal. Yes, there's a little bit of a low dose, what we call low dose bath around the target, but that low dose bath is probably less with protons than it is with photons.
Hmm.
The question really is, and where the rubber meets the road is, does that mean anything? And the short answer is, for the vast majority of published studies, is no. Everything has mostly come back as negative or no difference. The biggest one being a big prostate one that was just published this year, randomized trial comparing photons and protons, and basically found no difference. Essentially, did find no difference at all. And in fact, some of the raw numbers suggest potentially higher side effects with protons, but
Hmm.
that's beside the point. Basically, no real difference. So that was my long-winded way, and unfortunately, there's
Yeah.
really no short-winded way to explain it. But and obviously can go into more detail. But big picture, there are definitely scenarios where I refer a patient for protons. So for me, what's really, in my opinion, are the diseases where we don't give a lot of dose. So actually, it's the opposite of what you would think. The diseases where we want to give low dose is actually the most beneficial, because even if you have that scenario where maybe there's a little more biological radiation, it probably won't hurt them because the dose is already low.
Hmm.
And those are situations where we really want to do everything humanly possible to minimize the dose going elsewhere. So the way I view it is like craniospinal radiation for
Hmm.
kids. No brainer that they should be getting protons, because you can come in with a beam from behind. There's very little to no radiation to the heart, to the lungs, to all this stuff in a growing person. Makes total sense. And the dose we typically give is on the lower end of things. Um, Certain Hodgkin's lymphomas in young people, things where we're treating the mediastinum, upper mediastinum in young people, makes a lot of sense because the dose is low and every degree is going to matter in a 20-year-old woman's breast tissue. You
Hmm.
know, those are the tumors, even at very low doses, could lead to an increased breast cancer risk decades later. So
Hmm.
those are situations where, to me, I definitely want my patients to either get protons or at the minimum get an opinion on protons. I think, unfortunately, with what is mostly being treated with protons, prostates and things like this, I, in my personal opinion, best case scenario, it's no difference. And then worst case scenario, based on some of the earlier studies, again, a lot of that's been fixed now, potentially the higher risk of some certain side effects.
Hmm. Yeah. No, that was a good explanation. I think, you know, someone might say, well, if there's no difference in the efficacy and no difference in toxicity, then it's kind of a tough choice. But if you have same efficacy, more toxicity, obviously, you ponder whether proton therapy should be offered to anybody, right? When you see a higher rate of toxicities, and we've had some patients just anecdotally have some toxicities which are pretty major with proton therapy. So, like you said, the appropriate individual with the specific cancer that would benefit from proton therapy, all of us should be referring out for proton therapies in those situations. But no, I appreciate you explaining that, because I think it's a common question that comes up in our world, and we just need more guidance. And it sounds like there's more data to come to help
Yeah,
explain which diseases are best.
yeah, I think it's tough too. There's a lot of places that put patients on registry trials, which again, not really the best. But I think
Yeah.
there are randomized trials that are trying to get off the ground and run. The problem is it's a self-selecting group, because if you're a patient that's very motivated to get protons because of marketing or advertising or whatever, you're going to be very hard pressed to agree to enroll on a trial where there's a chance you may not get protons, right? So that's the
Hmm.
challenge. At least the way I practice is, if a patient express interest in it at all, or obviously if I think they would benefit from it, I tell them to please go get a second opinion. We're
Right.
like you mentioned, we have several in town. I have a good working relationship, obviously, especially the University of Florida, being an alumni, but
Hmm.
where I know and work with most of those doctors over there. So from my point of view, it doesn't hurt my feelings at all when a patient wants to get a second opinion, because at the end of the day, that's what it is, right? It's an opinion. And so, yes, we have data, yes, we have recommendations, but at the end of the day, you want a patient to feel fully comfortable with whatever treatment they ultimately elect to do. And as long as they go into it with open eyes and understand the data and understand the pros and cons and the risks and the benefits, to me, that's more important, regardless of whether they choose one or the other. But I would say the short answer is at the current moment in time, a lot of it is definitely market driven, rather than efficacy data driven,
Right.
is the bottom line. And, these machines are very expensive. These centers are expensive. So the treatment costs quite a bit too relative to photons. So the other question you were saying is, well, if there's no difference and there's similar side effects, the other piece you got to look at is there are patients unfortunately getting, could get huge bills, or their insurance companies could get huge
Hmm.
bills. So the system cost is very high. And
Hmm.
so it's just another topic for another day. But um, there's that piece of the puzzle too. One
Yeah, I could see how it's hard for a patient to decide, even if you go for a second opinion. How do you know
one
necessarily? I guess you kind of do a field test and see, if that particular center has the right technology and is doing it for the right reason. Obviously, that's why you go for the opinion and kind of feel it out. But there's a lot of variables that go into the treatment, like you said, and there's some newer updates to technology. How do the patients know whether those centers have those updates or not? It's just challenging. I could see how that's hard for patients to make that decision, but I think your explanation helps patients just be aware of that, and maybe they can ask the appropriate questions. And so hopefully this episode helped them ask those questions going forward.
And that's literally what I tell patients when they go for an opinion, if they want one, is I say, here's the questions I would ask, and then see how they answer it. Because again,
Right.
it's not one type is not inherently good or bad, as I said at the beginning. So
Right.
it's just a question of nuance, unfortunately, in most cases. And at the end of the day, this is the good and the bad of oncology and just cancer care in general in the United States. Is sometimes there is more than one right answer, and there's just going to be different pros and cons.